Top Med Talk.
Hello and welcome to EBPOM 2018, celebrating 20 years of evidence-based perioperative medicine here in London. I'm Joff, Lacey, and I'm very pleased to be joined by Top Med Talk's Desiree, Chappell, and also our special guests for this session, Malcolm West and Carolyn Johnston. Malcolm is an NIHR clinical lecturer and colorectal surgeon in Southampton and Basingstoke in the UK, and has undertaken a large volume of research into cardio pulmonary exercise testing and prehabilitation. And Carolyn is a consultant anaesthetist at St George's who has a specialist interest in quality improvement, and amongst her other roles is the improvement lead for the National Emergency Laparotomy Network. Welcome to you both. Thanks for joining us.
Thank you.
Thanks.
Malcolm, I'm going to start with you. We obviously know the general benefits of exercise, and you've done a lot of work into exercise prehabilitation in the surgical patient. Can you take us through where the evidence base stands in terms of the benefits that exercise prehabilitation affords the high-risk surgical patient?
Sure. So the evidence all started with the older cohort in Australia. So that was 1990s evidence. There was a big recent meta-analysis and systematic review, including about 5,000 patients, 39 studies published in the BJA in 2016, which essentially validate that argument of if you are unfit, you will do poorly after a big operation. So poor physical fitness, objectively measured by Cardio Pulmonary Exercise Test, will lead to poor outcome.
And what kind of programs have you been involved in which you try and manipulate that, so improve the fitness of patients before surgery?
So on the back of that, we published a couple of big observational trials, mainly in colorectal. That's because it's my pet interest. A big colonic and a big rectal group, again showing that poor physical fitness equals poor outcome. And then we looked at that cohort, and about 50% only 4 years ago had major intra-hospital complications. And using statistical models, we could predict that if you could improve even by 1 ml per kilo per minute in your anaerobic threshold, and by 1 ml per kilo per minute in your VO2 peak, which is not much, you could shift that risk band, and you could go from a high risk individual to a lower risk individual, hence shifting your morbidity. So we started off with a pre-pilot prehabilitation program. So it is non-randomized, published in the BJA again a few years ago now, which show that we can actually improve objectively measured physical fitness in a very short space of time. So within 3 weeks, using a structured responsive exercise training program, which was tailored to the individual patient based on CPET. And that had tenuous links to morbidity. And then we went on to get funding, which was key. We got 2 big NIHR research for patient benefit grants. One of them is called Empower, and Empower is going to report at the end of this year. Empower is exercise training after long course chemotherapy in patients having locally advanced rectal cancers.
And that's an important group, because take us through the kind of impact that chemotherapy has been shown to have. And
so we have again published on a couple of cohorts now, 2 locally advanced malignancies, one upper GI and one lower GI, totally different tumor biology. But they have the same platinum-based chemotherapy given to them, one without radiation and one with radiation. The upper GI cohort was fascinating in that everyone reduced both statistically significantly and clinically significantly their VO2 at 80 and VO2 peak. And that is related to 1-year survival. So their baseline fitness is now related to their 1-year outcome. So the impact of that is that the marginal gain from survival, which is put at about 12 to 15% on the big oncology trials, might be mitigated against by the toxicity and adverse outcomes by reducing their fitness. So not everyone is going to benefit from chemotherapy or a multimodal treatment, which is chemotherapy and surgery in upper GI cancers. And I think that's big. And the trial, again, is going to be published soon this year. Moving on to the rectal cancers, the survival benefit wasn't seen, but the in-hospital complications were exquisitely linked with changes in fitness. So people in the control arm who kind of spiral out of control and their fitness keeps going down will encounter complications roughly 60% of times, as opposed to the exercise arm, which don't.
You mentioned the time period of which the exercise programs are only about 3 weeks.
Yeah.
Does that reverse the effects?
Yeah, exactly. So in the rectal cancer arm, we have a 6-week program, and Empower is now powered for a 9-week exercise training program. That slots in nicely to the cancer waiting time. So in rectal cancer, the radiotherapy effect that shrinks the tumor will have, the longer you wait between the end of chemotherapy and surgery, the better it is. There is data now that shows that even if you wait up to 14 weeks or even 16 weeks in Europe, the benefit is better. So you essentially get a complete response rate of the tumor.
That could be a game changer. I think a lot of people listening will say, well, I do regular oncological surgical lists, and there's the time pressure. We're not going to be able to fit them through an exercise program.
Exactly.
With that kind of data.
Exactly. So the neoadjuvant cancer group is interesting because there's a time period. The converse of that is what you do with the straight to surgery ones, which are fitted into your 32-day target and a 62 NHS waiting time. There are things we can do. We are lobbying the government to stop the clock for these kind of patients and risk stratify on their baseline test to kind of signpost them into high and low medium risk groups and intervene on multiple fronts. So WestFit, which is our large, pragmatic, randomized control trial funded by the NHS and the SDP, is 1,550 patients over the next 2 years, looking specifically at that in different type of cancers. So HPV cancers, pancreatic cancers, urology, lung, upper and lower GI. And the primary outcome of that is reduction in length of stay with a co-primary outcome of reduction in morbidity in the exercise arm. And the multimodal intervention will be both exercise, aggressive nutritional phenotyping to inform an intervention in the future, and also a psychological intervention, which is extremely important, so an anxiety mitigation intervention.
Yeah, that was what I was going to talk to you or ask you about, is interacting with the patient and getting them on board for, one, waiting to have the surgery, because a lot of people, they want to get in as soon as they can to get the cancer out. So that educational piece, and then just the buy-in for let's do exercise as medicine, kind of. So how is that working, and what is the program that you put together for that?
The selling point of exercise as medicine is remarkably well adopted by patients. It is a very easy concept to sell. If you are fitter, you will get better, you will get out of hospital better, and even if you have a complication, you'll recover better. So people like that concept, and people buy into it. Surgeons buy into it, anaesthetists buy into it, and intensivists buy into it. We are lucky enough to have a very good cancer nurse specialist network in our region. They are totally sold with this idea.
Yeah, we're piloting a similar process based on how we've been inspired by Southampton, which Macmillan are funding, and they would describe it as a teachable moment. Yeah. So you go to your clinic and find out that you have a cancer or potentially have a cancer, and now you're told to go home and wait until someone will cure that or not cure it for you, and that's a big day. Whereas to say to them at that point, but there's something you can do to improve your chances. The vast majority of patients will grab that because it's such a teachable moment for them to take that on board.
Yeah. I think that's a life-changing moment, and without sounding harsh, if you can't institute an intervention then, when the patients are at a vulnerable stage, you will never be able to do that. So that's why prehab as opposed to rehab works better, we think.
Have you been able to follow up these patients long term and see whether they continue to change their activity levels?
Yeah, so we give patients physical activity monitors, and they are wearing it for up to a year now.
Wow.
So patients change their activity and change their behavior towards exercise mainly. And their change in behavior towards exercise is manifested by a change in activity. We know that patients through chemotherapy drop their activity levels severely. So in our rectal cancer cohort, they start off with about 8,000 steps per day, and then that goes down to about 1,500 during their chemotherapy week, and that has a massive effect on their physical fitness. But people who have a dog will walk their dog through their chemotherapy and after, and the change in activity will go back up. However, their exercise, their physical fitness, their objectively measured physical fitness will still spiral out of control if you don't institute an intervention. So it's the intervention and not the resumption of physical activity which will give you the benefit, we think.
And then have quite far-reaching general public health implications.
Absolutely.
Is there any evidence of the effect of exercise on the tumour pathology, the kind of microenvironment in terms of growth or metastatic spread or recurrence or anything like that? I mean, it might be a bit.
So there is, and that's where we're heading to. So we want to have it is nice to reduce length of stay and morbidity, but it would be even better to try and modulate tumor biology with exercise or a prehab intervention. So that's going to be published on our rectal cancer cohort again this year if I have time to write it. But we're looking at MRI scans, so people having, again, long course chemoradiotherapy for rectal cancer, the exercise arm have a much better tumor response than the non-exercise arm on MRI and on pathology.
Carolyn, if I could switch now from Malcolm's work with elective surgery, where we sometimes a shortened time period, but still we have the benefit of time and to consider prehabilitation. Your work as the improvement lead with NELA. Tell us more about that role and how you can kind of deal with the fact that these patients have landed on our doorstep.
So can you say, what is NELA first?
So NELA is the National Emergency Laparotomy Audit. So it's a national audit collecting data from emergency laparotomy patients in the UK. We cross-check it against the national data set. So we collect 85 to 90% of all laparotomies done in the UK. We have an extended data set related process and outcome measures, including up to 90-day mortality for all of those patients. And I think what sets this aside as what I would hope is a helpful audit is that data is immediately available to local clinicians. So they have their dashboards of process measures, and they have access to all of their own data immediately, as well as it going in the big old national report that comes out 18 months after the data is collected. It's available in real time for clinicians to use. So QI is a very big part of what we do.
And so you're the improvement lead. What have been the biggest challenges and the biggest wins so far in your work with NELA?
Yeah, I think as a specialty we still have an audit mindset, and I don't think that it's an either or. I think audit is important, assurance is important, that patients know that they're not going to a hospital that is an outlier for bad results. But for me, it's been a big piece of work, even locally in my trust, to make people realise that actually for us to collect this data and not use it immediately to improve our care is such a waste of time. To contribute to a national project and not for us to use that data locally is dumb. Yeah. So for me, the biggest challenge is to get people to say, actually, this is my performance data, how am I doing? And when I started, I thought, I'm going to have to rewrite pathways and change systems and process and so on. Actually, what I've mainly done is share performance data with people, and that starts the conversation, and they do it themselves. So I find the kind of whole system change and reconfiguration hasn't been necessary because individual people, once they know their own performance, are able to make most of the changes they need to make.
Just publicising those results, as in within institutions?
Yeah, so to say, how many of our patients go to the intensive care unit, high-risk patients go to the intensive care unit. We have that publicly available on the dashboard, and that really encourages the ITU to take more of these patients, and it encourages us to know that it's the right thing to do to ask.
We were talking to Professor Rupert Pearce earlier about the EBPOM study and talking about quality improvement, implementation, etc., and how one of the things that came out of the EBPOM study was not necessarily that people didn't have the drive or the knowledge to implement quality improvement, but it was just the resources and it not being there. So how have you found that locally, but also in your kind of more national role with NELA in terms of how people manage that?
Yeah, I think you have to be quite clever to make the time and space and resources for it. And that's not to say I've been clever and I've solved it, but that's to say that I've had to look hard at our data and think, well, where can I bring most value to what the hospital wants me to do with it? So I look at, for example, sepsis, and I say, oh, good, the hospital's pretty focused on sepsis, and so is the ED. Maybe I can tack on my emergency laparotomy patients to an ongoing piece of work and thereby, potentiate the amount of interest and the amount of activity I can get out of that. Similarly, talking to our managers about our length of stay. So for me, emergency laparotomy mean length of stay of 21 days is, a acute medical inpatient stays in hospital for about 5 days, and there's a whole team of people working on medical inpatient flow. And so I go to my managers and I say, did you know that our patients are staying in hospital for 21 days average? Then I can get them to take me seriously and work with me.
Do you think there's enough assistance at a national level for people to do this? I mean, you're in a position where you're well networked within your institution and within quality improvement.
Yeah.
But if you're trying to make improvements, in your own institution, do you think there's enough support?
Yeah, and I mean, you need a lot of resilience to make that happen, don't you? So I think there's a few things that we've done, actually, even just the immediate reflection on the EPOC results to say, well, okay, what we've thought about capacity and capability for improvement, but what they've really showed is the issue is the barriers. So we can address capacity and capability by encouraging trusts to give their NELA lead a PA, or by running teaching programs, which we do, by having animations to help them use their data, which we do. But actually, probably what we need to do as a national audit is to say, well, how can we help you with these barriers to care? And that process had already begun, but I think we're going to work harder on it. So, for example, helping people write business cases for elderly care liaison so that they have something that they can modify and use, or helping them with, we produce a exception report, which is ready to just stick in your morbidity and mortality meeting. So say, look, here it is. We've made it as simple for you as possible if you go and use it.
This is available now for people to...
Yes, it is. So we've made a excellence and exception report, we've called it. So it details on 2 pages for each trust patients who died who didn't meet some key standards of care, and patients who've had every single standard of care as recommended by the audits met. So we felt one or the other presented on its own didn't quite seem right. So the exception and the excellence reports come together.
Yeah. Have you been able to pull out generally what people describe as being the biggest challenges to them? Does that come out a theme across the...
So we've run a series of workshops. So we've run 8 workshops over the past 6 months or so around the country, and they've been a really rich source of data, qualitative data, people talking in their groups. So in a region, say for example around Manchester, local leads from all the trusts, surgeons, anaesthetists, and usually audit leads come together, and they've been discussing their care, and they've been really helpful. It's not one-way traffic. It's not us telling them about the audit, it's them telling us about the audit too. So that's been really helpful and given me a bit of a to-do list of things I can do to help them. But building on that, we've got this project in England with the Academic Health Science Networks, which are regional networks to spread good practice and innovation in the NHS. And they have picked up the Emergency Laparotomy Collaborative bundle of care, or the collaborative series idea, to work with emergency laparotomies. So we will hopefully see this kind of cross-collaboration locally as a really helpful thing, because I know that it's very hard to work on this if there's no one else in your trust that wants to listen to you. But coming together in a group, I think is going to be very helpful for them,
It's always, I'm amazed when I'm over here and listen to some of the coordination of national quality improvement programs and how it really is making a huge difference. And in the U.S., I feel we're really far behind, but the lack of resources and just coordination as a whole is such a barrier to us doing some really major improvement in our care. But Malcolm, do you actually use the NELA data?
Definitely.
Yeah.
I'm on call this weekend. some people will definitely go on there.
You might have to be making some entries.
Yeah, definitely. I think that's a really good idea. And we're in Wessex. There's a research trainee collaborative, and they have launched as a trainee collaborative a frailty sarcopenia piggyback project onto NELA as a Wessex-wide thing, and that has been really adopted by the CRN now as one of the examples of trainee-led research onto a quality improvement project like this, and it's commendable. It's great.
Yeah, that sounds great.
There's been a few of those nationally too. So the Alpine study that came mainly out of the trainee-led network in London looked at ventilation parameters in emergency laparotomy. And the Northwest Research Collaborative looked at frailty. The ability to kind of customise the data set for your purpose, I think, is really helpful. Absolutely. Let's see more of it.
Yeah, this has been quite a success story, the trainee research networks, haven't they, particularly? So,
the West Midlands, especially from a surgical point of view, they have contributed to the literature enormously just by limited funding and having a good trainee base, well supported from really good peers like Professor Dean Morton, etc., etc.
Well, look, guys, thanks very much for joining us. We're going to have to leave it there because the next session is starting. Thank you for listening. You can catch us on the TopMed Talk website, which is topmedtalk.com, on Facebook and Twitter, and you can continue to listen to the live feeds from the sessions here at EBPOM. Thank you for listening, and goodbye for now.
TopMed Talk.